Good evening, ladies and gentlemen, and welcome to this webinar. What I want to discuss with you today is a little bit about some of the advanced immediate placement strategies, including the socket shield technique, and more importantly, some of the complications that I've had to deal with over the years that I've been doing this technique. Now, when we're talking about advanced immediate implant placement, there's a reason why we've developed these new techniques, and there's a reason why we've had to develop some of these advanced techniques. And the reason is that the aesthetic zone is a very, very difficult zone to deal with immediate implants for various reasons. When we go into the aesthetic zone, what we want to do is we want to talk about three different areas, because it's really these three types of areas where we have our major problems in the aesthetic zone. The first one is the single implant site. The second one is the multiple implant site. And the third problem area that we have is thin gingival morphotypes. Now, what I'm going to go through now is I'm going to go through each one of these areas. I'm going to point out and highlight why we have problems in these areas and why the need for these more advanced type of techniques in immediate placement. If we look firstly in the aesthetic zone with single implants, we know from Schropp in 2003 that we get extensive buccopalatal collapse, especially with immediate implant placement. Okay, we also know from many of the studies, Chen, etc., that we get gingival recession, more or less around 1 millimeter. But more importantly, what does happen when we have a single implant is that we do generally tend to maintain our papilla. And one of the reasons for that, as I'm sure you know, is that the papilla is based on the bone of the adjacent teeth. So when we're dealing with a single implant, we really have two major problems, and that's the gingival recession and the buccopalatal collapse. And a lot of these can be sorted out quite simply using soft tissue grafting techniques and things like that to bring the gum down or to plump out the gum. The one thing that does lead us with a huge problem is the papilla and the loss of papilla with single teeth, because unlike multiple teeth where we can add pink composite, with a single tooth it's actually not possible, and once the papilla is gone, it's really gone. And we really need to be very, very careful here to make sure that we don't raise flaps, that when we see that some of the bone's gone, we try and prevent loss of that tissue as much as possible. And that's really where your immediate placement comes into its own, because without raising flaps, doing flapless procedures with immediates tends to keep the soft tissue and the papilla intact as much as possible. So with single teeth, we have certain problems that we don't have with multiple teeth. We get some buccopalatal collapse, we get some gingival recession, and occasionally we get loss of papillae, but generally the single implant case is really one that we can handle quite well. When, however, we get to multiple implant cases, now we start to deal with a whole lot of different problems. And the reason that we have different problems is because we get far more buccopalatal collapse. And if we look at this case 3 years post-op, you can see that even though everything started off with a fairly good bulk and everything looked nice, a slightly thin gingival morphotype, and as a result, 3 years post-op, you can see loss of papillae, loss of buccopalatal dimension, recession, everything going on there as a result of the multiple teeth that are taken out and the extensive and more widespread collapse of the buccopalatal as well as the vertical dimension of the bone after healing with immediate placement. And if we look at this other case here, you can see another 5-year post-op case where the 3 anteriors were extracted and the implants were placed. And you can see the gingival recession that's taken place. You can see the buccopalatal collapse. And on the upper left lateral, you can see as well where you're starting to get even further recession 5 years post-op. So a lot of times what we see when we go to conferences, we see fantastic cases, but what we're not told is that these are actually immediately post-op. And as soon as we start going to our 3-year and our 5-year cases, we start to see really a different process. And with these type of techniques, in this type of situation, we are lucky whereby we have now the techniques as pointed out by Garber and Salama and by Coachman, where we can use wonderful pink composites to start to work these things. But what we're really looking for is we're looking for something that prevents this kind of thing from happening, and that's what we're going to talk about today. The other thing that happens very extensively, as you can see in this case where we had a patient with a very high lip line, a very high aesthetic value case, and you can see the massive amount of destruction and resorption of the ridge and the pontic sites, and we can come here and we can do multiple grafts, but essentially we're never going to get that whole thing back to where it was. Again, pink composite does help us in these kind of scenarios, but in the day when this case was done, we weren't really using too much pink composite. So from that point of view, the case was really a disaster. The other difficult area that I want to talk about is thin gingival morphotypes. And we know from Evans and Chen that when we're dealing with a thin gingival morphotype, we definitely have far more recession and we have far more buccopalatal collapse, as you can see in this thin gingival morphotype case that I'm showing you here. We also know that we have increased soft tissue discoloration because of the fact that we've got a thinner soft tissue, because of the fact that we get far more collapse and there's a more exposure of the implant, as you can see in this case. Despite the fact that we've got a very good soft tissue outline, you can see that the tissue is discolored and you can see that there's something not 100% right with the case. And another thing is, you can see with this case is the kind of case that we show and we say, ooh la la, what a fantastic case. Give this case a couple of years and you might find that it's not looking as good as it is now, even though it's still not a perfect case with regards to the coloring. And the other thing that I find, and this is not something that we can give any scientific proof for, but I find that with the thin gingival morphotypes, they definitely don't respond to the type of grafting procedures as well as other situations, as described by Joseph Kahn in his study, where he shows the change of morphotypes. And I'm not sure if other guys have found that as well, but certainly in my hands, and I'll show you another case just now, certainly thin gingival morphotypes tend to give us the biggest amount of problems. So with these type of things, with multiple cases, and with thin gingival morphotypes, what can we actually do? And what is the reason for this, for all this to happen? So let's look a little bit at the cause. And this was first highlighted by Araujo and Jan Linley in their 2009 study, where they showed us that really the bundle bone, in other words, that thin little bit of buccal bone outside of the tooth, really belongs to the tooth. We know that it belongs to the tooth, and the minute we extract that tooth, that bundle bone disappears. And if we look at the study by Nevins in the International Journal of Perio and Restorative in 2006, he also showed that after extraction, here you can see the images from his study, you can see that thin piece of buccal bone that he has on the outside, and 6 months post-op, you can actually see the resorption that takes place in an apical and a buccopalatal direction, and you can see 6 months post-op where you've actually lost the entire buccal plate and you really end up with minimal bone there. So you can understand that if you've placed the implant into this area and that buccal bone's gone, that essentially you are sitting with an implant which just has gingiva sitting over it. If we look a little bit closely at the histology of the case, you can actually see in this case, you can see the nice. I've highlighted the bone here. You can see the bone on the outside and labeled A. You can see the periodontal ligament labeled B, and you can see in red all the vessels. And now it is these vessels which support that bundle bone. And the minute you take out that tooth and you lose those vessels, there's not enough nourishment for that alveolar bone. As a result of that, that bone disappears. So let's look a little bit at recognized treatment strategies. What have we used up until now? You know, obviously we realized that there were some problems. Chen and Boozer came up with the whole thing in 2009 that we shouldn't be placing immediate implants. And what happened is we've had strategies pointed out by Uli Grunder, where he suggested that we use narrow diameter implants for immediate placement, and we'll discuss why. We, from Boozer and Chen, in their iJomi article in 2009, in their systematic review, they spoke about the fact of a need for a delayed approach in high aesthetic value cases rather than an immediate type protocol. But unfortunately, the one thing about that article is that there was very little data to back up what they were saying. In other words, there was no data to show the one better than the other. It was more a suggestion. The other thing that we can do is we know from Uli Grunder's study, connective tissue grafts using the tunnel techniques, which works very, very well. And we also know that we need to place our implants deeper and more palatal, a la Kovani's International Journal of Peri and Restorative article. So let's look at those treatment strategies, and let's have a little bit of a look and see what the whole process around it. And if we look at the treatment strategies and we use Nevins's cone beam CT, you can see the type of destruction that's taken place. And if we use the protocols as designed by Grunder, you can actually see that if we place our implant deeper, and if we place our implant more palatal, that we'll actually have a situation where when the whole socket heals, we will have bone covering the whole implant, even though we will get that buccopalatal collapse. And if we look at a case of mine, which has been going for a hell of a long time, this is a case that's been going now for almost 8 years, and you can see the upper right central with this is a 6-year post-op, and if we look at the cone beam, you can see outstanding buccal bone, and if we look at the inclination of the implant, you can see deep and palatal and narrow. This is a 3.5 ankylos implant, which is placed very deep and very palatal, and as a result of that, the buccal is covered with bone. So this is the one treatment strategy. The other treatment strategy is from a study by Grunder, and Salama and Gob have also put a study out in a similar vein to this. And basically what they did was they did a connective tissue graft with the tunnel technique. And what they showed, if you look at the results below, it shows an average loss of volume in the non-grafted sites of about 1,063, which is pretty much what Schropp and Chen and all the other Botticelli have shown in their articles. Whereas in the grafted site, there was actually a gain of 0.34 millimeters. So when you grafted, you didn't just lose, you actually gained some of the connective tissue. So let's look at some of the cases that I've done over the years, and you can see here pre-op, and you can see the immediate placement. And if we draw a line, you can actually see that we had less soft tissue on the left-hand side when we started, but as soon as we bulked it out, you can see how we've actually augmented that tissue and a nice thick gingival morphotype that we've created. And 6 months post-op, you generally see this absolutely exquisite ridge with beautiful soft tissue, and with the provisional back in place, you can see that it's absolutely stable 6 months, a year, and many years post-op. These kind of cases are very, very good and stay very well. But remember, and this is something that you'll see many times if you watch the cases closely at any conference that you go to, that the cases that are shown are all thick gingival morphotypes. Here's a case that we did a couple of years ago, and you can kind of see, this is in 2009, and you can see what's happened. In 2009, the upper left central, we placed an implant, we did a connective tissue graft with a tunnel technique, and you can see pretty much that over the years, initially everything was stable. In fact, we brought the soft tissue down, but a year later, the soft tissue had receded, and the tissue's still not looking as healthy. You're still getting some changes. Is there something happening with the bone underneath there? Have we lost all the bone? Is the implant shining through? These are all questions with thin gingival morphotypes. So as you can see with the thin gingival morphotypes, and as you can see with the multiple implant sites, we really have a major problem, because we can't do the connective tissue grafts over multiple teeth. They don't work as well as the single teeth, because we need papilla in order to bring the teeth down, and we lose papilla the minute we take out multiple teeth. Also, the thin gingival morphotypes, is there not another technique? And this is where we can start talking about new treatment strategies. And the new treatment strategy that comes out that is really, in my humble opinion, really something that's phenomenal, is the socket shield technique. And the socket shield technique is a technique which was first described by Marcus Hertzler, Otto Zur, et al. in the clinical periodontology in 2010. And basically, what their whole process was is they left a piece of the buccal root intact, and they left it there so that the body didn't actually know that the tooth had been extracted. In other words, the periodontal ligament was still there. Now, if you remember going back to the slides, because the periodontal ligament was there, what was there is the blood vessels were still there. And because the blood vessels were still there, we still had nourishment for that bone, and the bundle bone stayed behind and did not resorb at all. So with the placement of that implant into the place, they actually found in their histological study that it retained the buccal aspect of the root during implant placement, and it does not appear to interfere with the osseointegration and may actually preserve the buccal plate. So for the first time, now is something that's incredibly exciting, because In a case where before we had nothing, now we've got something where we can prevent total loss by keeping the buccal plate. So if we look at this case, if you can have a look there, and there are quite a few lectures that have already come by some really great guys doing the socket shield technique, and they've got some really great graphics. So watch those lectures as well, because some of the stuff will maybe give you a little bit more insight that maybe I'm not showing with poorer graphics that I might have. But you can see here essentially what we're looking to show with the graphic is we're looking to leave a small piece of plate. And if we have a look there you can see a buccal shield that came out, and you can see pretty much what we're looking to create by leaving that piece, by taking out the palatal portion and then placing our implant. And if we continue through with this case, you can see here, this is the technique that was originally described by Marcus Hertzler and Otto Zur. And what they did is they took implant drills and they gradually expanded the implant hole through the tooth, and then once they'd expanded it wide enough, as you can see from the slide on the right hand side, they then created small cuts on the mesial and the distal, and once those small cuts were made, they then took out the palatal root, leaving only the buccal shield. Once the buccal shield was done, the implant was placed. And in this case, we did what we call the walkout as you walk in. As a lot of you who know my work will know, this is the way I prefer to do, is to put the patient's own crown back in their mouth so that they have very little idea of what's actually happened, because it looks absolutely the same as it was before, even if the crown didn't look as great as it could. And with everything set inside, you can see the phenomenal soft tissue that we've created and maintained. And this is around 8 months post-op, I think, or 6 months post-op, I can't remember. But you can see the phenomenal lack of collapse, and you can see the lack of recession in this case, and you can see the beautiful healthy tissue. And if we overlay the previous and we overlay and we go back to before, you can see there's very little buccopalatal collapse. And if we go and we have a look at the slides, you can actually see the phenomenal bulk of the tissue, and more importantly, you can see between the central and the two centrals, you can see a wonderful papilla between the central and the lateral. You can see a wonderful papilla. If you look at the occlusal shot, you can see the occlusal shot, there's very little, if any, collapse of the buccopalatal tissue. Now, I know a lot of you will turn around and you'll say, but yes, but Howard, that's all very well. But the fact of the matter is that if I've got good papilla, the reason the papilla are there is because I've got adjacent teeth. And you'd be right, okay, because the adjacent teeth, the bone on the adjacent teeth will keep the papilla in place, a la Tarnow's 2000 article on Salama's interproximal height of bone studies, etc., and things like that. But what you don't know is if we have a look at the x-rays, you can see here that what we're actually doing is we're putting an implant next to an implant. And if you look closely, you will see that what we've got here actually is two implants next to each other. So if you go back to that slide and you have a look and see how well the papilla is there and how little collapse we've got, the fact that we've got the buccal shield is the sole reason that we've managed to maintain that, because if we didn't have the buccal shield, we would actually start to lose more dimension on the implant next door as well as where we place in the implant. So we get total collapse of that ridge, whereas the buccal shield in this case has held everything together. And here you can see a little bit from the cross-section what a buccal shield looks like on co-beam CT scan. And here's just another case just to show you how wonderful the soft tissue looks on this upper left canine. And remember that canines have the most bulbous of bone, and they tend to collapse the most because of the fact that they have bulbous bone. And this is a thin gingival morpher type case, and you can see how beautiful the soft tissue is. Now, unfortunately, this case doesn't stay like this because we had a complication. I'll explain to you why. It's got no reason, but it does show you the beauty of the soft tissue with the socket shield technique. So let's look now a little bit at the socket shield workflow. Let's go through the workflow. And basically, the workflow goes with the removal of the crown, the splitting of the root, removal of the palatal portion, development of the socket shield, the osteotomy preparation for the implant, implant placement, jump gap management, and finally provisional or custom abutment placement if possible. So if we go through that in a pictorial essay, here you can see we are using a tungsten carbide burr to remove it. I'll show you the one I like to show a little bit later in the video. Once we've got everything cut flat and ready to go, what I like to use, I don't like to use the implant drills for many reasons, and I'll show you some of the complications I've had as a result of that. Number one is the possible loosening of the buccal fragment because of the vibration of the drills as you get wider. The second one is that you get very little cooling, which means that you heat the apical portions and you can cause failure of integration because of overheating of the bone. And the third one is you can cause infection with those types of things. So what I prefer to use is a comet drill, and if anyone wants to know what the numbers are, I'll tell you about them. But these are long shanked root resection burrs on a fast turbine handpiece, which allow you to cut effortlessly through the root and don't do any damage and cause very little vibration and very little damage to the bone or the tooth, and allows you to just get a much easier removal. Here you can see the removal of the palatal portion, and we'll go through this in more detail in the lecture. Once we've removed the palatal portion, there's the preparation of the socket shield, and you can see removing the apical portion, further preparation. Okay, preparation there you can see with retraction, and I'll explain to you why it's so important to do the retraction. And there the socket shield finally prepared. The implant placed into the socket. Again, we want to use as narrow an implant as possible, but obviously one as wide as necessary, as prescribed by the type of implant that you're using. So don't go decide that you can use a 3.5 on an implant where the manufacturer actually tells you need a 4.5 for that tooth. You have to be very careful. So we have a policy where it's as narrow as necessary, as narrow as possible, but as wide as necessary. Once we've done that, then we do the packing of the jump gap with synthetic bone. We use a xenograft, and once we've done that, then we place our cover screw. Either, as I say, I prefer a custom abutment these days. I don't like a standard abutments that come with the kits. I'll explain why a little bit later. And the other thing that we want to do is try and fit the crown if we can to help to shape the soft tissue. So let's look at this case over here. You can see this is a classic type of case. You can see it required a DSD, which we did. And if you have a look at the smile, you can see that the DSD was necessary not only from a gingival point of view, but also from an incisal point of view, where the left side was too high, and on the right side the gingival was too low. We also had a biological width invasion on the upper right hand lateral and central incisor, which required some treatment, and we also needed an implant in the upper left central incisor because of the fact that it was a ferrulous root, and we needed to place an implant in that position. So following crown lengthening, doing our DSD, getting all our stuff into position, showing everything the way we wanted. We did the DSD and we did our socket shield pretty much the way we described. We placed our implant more palatal, a little bit deeper, collect our jump gap. And you can see the final result with this kind of case, where you can see the phenomenal soft tissue development. If you look at the occlusal view, you can see there's absolutely no collapse. If you look at the buccal view, you can see between the lateral and the central, you can see good papilla. You can see between the two centrals, you've got fantastic papilla. Again, these are cases, obviously, one says, okay, well, it's a single implant. If it's a single implant, our bone is good. And again, I will show you a case where we have put two implants next to each other, and still we are maintaining phenomenal bone. So for the first time, we have a technique which, for thin gingival morphotypes, number one, and more importantly, for multiple implants, we can maintain our papillary height, we can maintain the buccopalatal dimension. So you can see why this is such a phenomenal and fantastic type of technique that we can utilize in our strategies for treating immediate implants. Let's now go to a little bit of frequently asked questions, because you often see when we post stuff, and I see when other people post stuff, there are a lot of questions that people ask. So what I've tried to do in this lecture is just to go through a lot of these lectures and just give you an idea of what it's all about, and just answer the questions pretty much before they come through. So the first question we have is, how long should the socket shield be? Second question, what do I place, what level do I place the implant? Do I place it at bone level, at socket shield level, etc.? How high should I leave it above the buccal bone? In other words, how high should I leave the socket shield above the buccal bone? How thick should the socket shield be? Do I need emdogain to recondition the root? How much space should there be between the socket shield and the implant? And do I fill the jump gap? Okay, so a lot of very, very important questions, and I'm going to go through each one of these frequently asked questions and answer them in the best way that I can. The one thing that you must understand is that there's very little data to go on. In fact, there are probably about 3 or 4 articles only on this technique, and certainly no long-term data on this technique. So the jury's still out, but certainly from Hertzler's point of view, the technique is now on the 5-year level. So I expect that we'll see some 5-year data coming out from him very, very soon. The stuff that I've been doing is about 2.5 years old. So I've got about 2.5 years of experience with the technique. So what I'm going to share with you with answering the questions is a lot to do with the first articles that were published by Hertzler et al. And by Baum et al. And the rest of it is really going on my experience and also listening to other clinicians and how they treat their cases. So the first question is, how long should the socket shield be? And there isn't really an answer to this, but certainly from attending one of Hertzler's lessons, what he suggested was that you require 6 to 8 millimeters of socket shield. Now I can tell you straight out, and if you look at the scan on the left and you look at the scan on the right, you can see they're vastly different lengths of socket shields on the one side to the other. And I don't think there's any data to show that you really need one size or the other, and you could even leave the entire buccal wall in there. I don't think it makes much difference at all. The critical thing is that there's no infection on that root. The critical thing is that that root is not mobile in any way, because if there is any mobility, you are going to have an infection and it will destroy all the buccal bone there. And as long as that buccal piece is stable, it can be as long as the whole implant. It can be fairly short, but you want it around 6 to 8 millimeters, and the reason for that is it gives you the maximum amount of stability and hold against the buccal wall of the bone. But certainly length, I would say nothing less than 6, but you could be as long as it needs to be, as long as you take out the apex of the tooth and as long as you remove as much as you can. The next question is, how deep should I place the implant? Okay. Now, if you look at Baumer study et al. In 2013, okay, they will tell you that the implant should be placed at around 1 millimeter below the socket shield, which means in essence that your implant is at the same level as your buccal plate, as I'll show you when we answer the next question. But the essence is that if things go wrong and you leave that at the buccal plate, I find that it's a little bit too shallow. And if we go by Cavani's recommendations of palatal and deeper, I would prefer to place it around 2 millimeters, and that means that it ends up 1 millimeter below the buccal plate of bone, which I think is the ideal position. I think that's where we should be looking to place our implants, is around 2 mils. Again, there's no data, and I'd be great to hear other people's comments on what they feel about this and where they would go with this, but certainly my feeling is with this type of thing that 2 mil is really where you want to go to. And here you can see different cases on the left and the right. Once on the left-hand side, it's about 2 mils below. On the right-hand side, it's about 1 mil below. Both cases work very, very well. And it's really just when things go wrong that you want to have your implant a little bit deeper, because it's far easier to fix if it's deeper than it is if it's shallow. And I'll show you when we deal with complications. So let's look at the next one. And the question is how much space should there be between the socket shield and the implant? And the answer to that is it doesn't have to be any space at all. And this, I think, has been clearly shown in Boehmer's study in 2013, where he showed the histological stuff completely, where you look at the micrograph on the left-hand side, where you can actually see where the bone, where the implant had cut into the tooth, and how bone is actually eaten away and formed around the threads of the implant anyway. So it could touch. The most important thing is that you don't want too much pressure that it's going to actually push it out or cause movement of that plate. And I think that's the critical issue here, is that you can lightly touch it, but do not cut into it, because cutting into it may mobilize it and loosen it. And remember, if you have a loose socket shield, it will cause an infection and destroy the bone. Okay, and you can see the numerous cases that I'll show you over here, where I tend to keep it as far away as possible, and I'll follow the Cavani protocol very, very strictly as much as I can, but you can see on the upper right-hand side, we've got cases which are much closer where you don't really have too much space. You need an implant that's slightly wider. You need to use something that's going to go closer, and some are close, some are far. But if I had my choice, my protocol would be to try and keep it as far away as possible from the socket shield as I can, to allow as much bone to form, and also to make sure that should there be a complication, that I have the implant in the ideal position for me to fix. The next question that comes is, do I need Emdogain? And the reason for that is that Marcus Hertzler, in his original study, used Emdogain against the root before they put the implant in. And basically what happened when they used the Emdogain, as you can see from the micrograph, you can see the NC means new cementum. So what happened was they actually formed cementum between the implant and the dentine of the root. So there was cementum formation, there was actually fiber formation, etc. That occurred there. So what they did have is they had this new cementum, but they didn't get bone. Now, if we look at Boehmer study, which also, funnily enough, includes Otto Zur and Olga Menzel, so it's all the same group. The next study they did in 2013 with histology, they didn't use Emdogain. And if you have a look at the micrograph again, it's a similar one, it's the same one we used before. You can actually see that they formed bone around the implant. And I think what we're looking for, rather than new cementum, we're looking for bone. So from my point of view, and again, it's just there's no long-term data. So this is really feel-good stuff, and what I see and the way I interpret the studies, and you might interpret them differently, and if you do, there is no issue to using Emdogain. But to go putting a very expensive material in to get new cementum, I would rather use nothing like that, and rather just get the good bone around, which is exactly what we're looking for. The next question there is, do I have to fill the jump gap? And I think the essence there, again, there's absolutely zero data. Now, in both Boehmer and Hertzler studies, neither of them used anything to fill the jump gap. However, I'm a firm believer. I follow Wilson, Cornellini, and Palontini et al., who basically suggested that as soon as you have more than 2 millimeters of jump gap, you want to fill it. And if you do fill it, you tend to get better bone than not. I prefer to stabilize the clot. If you do have very little bone, like you can see in the central photograph, there's very little space. Those kind of cases, you don't need to. The blood clot should stabilize on its own very, very well. But generally what I prefer to do is I prefer to place bone in there. I like to also use the dual zone therapy technique as described by Stephen Chu and Dennis Tarnow, to also support the soft tissue from collapsing at the top, and we'll talk about that a little bit later. But again, the jury's still out, and there's really no data for us. So I think it's really, you can use it, you don't have to use it, and you kind of need to work with it yourself and play with it and see what you feel is necessary there. The next common question is, how high should I leave the socket shield above the buccal bone? In other words, where should I place the socket shield to? Should I sink it? Should I cut it flush with the bone? Should I leave it at the gingival margin? And the answer to that, which is explained in the article in both Boehmer and Hertzler, is that you should leave it around 1 millimeter higher than the buccal bone, and that's just to allow the normal biological width so that you don't get recession of the buccal plate. And here you can see a close-up photograph of a probe, just measuring to see that they're doing a bone sounding on the buccal to check and see that we've got 1 millimeter between the buccal plate and the gingival margin. And the top of the socket shield. And if we have a look at Boehmer study et al., you can see from the histology that what heals afterwards is that we actually get a long junctional epithelium forming over the root as well as against the implant, so that it actually covers it up and seals it nicely so that we don't really have a problem. This is a really great micrograph to show us what happens with the healing process and how well it actually manages and holds the socket shield. The last question that we're going to deal with is actually how thick should the socket shield be, and this again has not been dealt with in any of the studies. And basically, I've done some things over the last few years, and on the left hand side you can see the 1 millimeter that we left, the 2 millimeter in the middle, and the 2 plus, which is generally around 3 millimeters on the right hand side. And from my experience, and what I can suggest is that you should leave it as thick as possible. I would go for around 2 to 3 millimeters max. I wouldn't go thinner. And when I did the 1 millimeters, I actually had some complications, because what happened with the 1 millimeter, although it was very, very nice, it tended to fracture much more quickly. And also the other issue with it is that we tended to get a situation whereby the socket shield would flex, and as a result of the flexion it would come loose, and we had some complications with loosening socket shields which were less than 2 millimeters thick. So we've gone back to a thicker 2 millimeters and a 2 millimeter plus socket shield, as you'll see in some of the next cases, to make sure that we get less flexion and that we really get good stability of that buccal plate with our socket shield. Let's move on now to some other issues, and that is actually doing a socket shield with simultaneous bone grafts, because often we get situations where not only do we want to extract the tooth, but we also have apical fenestrations. Now, certainly buccal dehiscences, there is an article that deals with this, where you can, where with that you can actually make a cut through the crack on the buccal, but it's not something that I do at all. I don't like that technique, and I prefer to do a graft in that technique, or using the immediate dentoalveolar restoration technique by De La Rosa. But here you can see a socket shield technique with simultaneous grafting, and here you can see not a high aesthetic value case for this patient. She really has a very poor aesthetics, but the cutting of the socket shields on the left hand side, the removal of the palatal, the preparation of the socket shields first. Following that, we do an aesthetic buccal flap as described by Maria Steigmann in 2007, Journey of Peri-Restorative. And you can see the apical areas that we have both on both of these implants. And as a result of that, we clean them out and we cut all the root off so that there's nothing shining through, as you can see on the left-hand side. And once we've done that and we've removed all the infected material, we place our implants into position. Again, palatal, deeper, a la Cavani. We do our buccal bone augmentation, and here we're using the botus material, the cerabone, as well as the adjacent membrane, which is a pericardium membrane. And it's certainly the kind of membrane that I only use these days, because the pericardium membrane certainly has a lot longer lasting time, and we tend to get far better bone, in my opinion, compared to the collagen membranes. Obviously also using APRF, using Joseph Chukrin's technique, and closing everything up. And you can see again filling up the jump gap with the cerabone. And here, because we couldn't get primary stability, we did customize the abutments. And the reason we do customize the abutments is it helps to support the buccal soft tissue and prevent that collapse of the buccal soft tissue, so that we don't end up with a situation where we've placed normal healing abutments, the soft tissue's collapsed over, and we still end up losing 0.5 millimeter of our gingiva. So this way we support it. We do dual zone therapy by packing the bone as high as possible as well to support the soft tissue, a la Stephen Chu and Dennis Tarnow. And you can see at when we did the final integration check, you can see the post-op scans, and you can see the beautiful buccal bone that we've created. And this is around 8 months post-op. And when we have a look at the case, you can see the ISQ levels, the values very, very high for both teeth, and you can see the beautiful healing of the aesthetic buccal flap, the outstanding soft tissue response, and zero collapse. And here you can see where a colleague of mine has created the provisionals, the soft tissue a little bit mangled after the provisionals have been put in place, and the interproximal area still needs to be opened up a little bit, because that papilla will fill in there nicely before we go for the finals, which will happen in a couple of months' time. What I want to do now is I want to go through a video, and I want to go through the whole description of this technique with this video to show you how we do a socket shield with immediate provisionalization. This patient came in to see a colleague of mine, and you can see the two poor endos, the crowns were removed, the endos were redone very, very nicely, but ending up with very, very thin pieces of tooth at the top, and one of the teeth unfortunately fractured with the provisional in place. And we decided at that stage that we'd remove the upper right central. Unfortunately, it wasn't the upper left central, but the upper right central was the one that went. The patient didn't want to do anything with the upper left one. She wanted to leave it as is with a fairly low lip line, thick gingival morphotype. So here you can see what we're doing is we're using a lab putty, which we're going to index the crown so that we can replace the crown in a walkout as you walk in technique. It sets very, very quickly, keeps everything in place. It's very, very rigid and firm, so you don't need to use any tray for it. And we'll put that aside now. What we're going to use is a very thin round tungsten carbide drill. And the reason we do that is that if we use anything longer like a diamond or anything like that, we tend to cut into the crown, whereas this one cuts into the root and does not do any damage to the crown, so we can keep the crown completely intact and it does no damage, and we can take everything off. And you can see how the composite shell came off. Here, this is what we're left with now. We're left with the root. And with the root intact, we are now going to use a Comet drill. Now, this is a Comet long-shanked root resection burr that we utilize, and it's very, very useful because it cuts very, very cleanly, and creating a smile-shaped cut from mesial to distal, and slowly working our way mesial to distal, very, very careful. And it's a very slow technique. It's not something that you want to go as fast as you can, because really, it's something that you need to develop a feel for how fast you're going mesial and distal to make sure that you don't overcut, cut into bone, and cut the buccal plate as well. So you can see we're slowly going deeper and deeper, going further and further to the deeper area. We know the angulation of our tooth from our cone beam CT, and the most important part, as you can see here, is I'm putting my finger on the buccal plate. The purpose of that is for me to feel when the drill is coming close to the buccal plate so that I don't cut through it. If I do happen to perforate the buccal plate at the apical area, it's not really a problem, because if I can place my implant more palatal, I'll be able to pack some synthetic bone down there. I'll have no issue. But you can see here where we've created that roundness. Once we've created that, again, my finger's on the buccal plate, because what I'm going to do is I'm going to move here using the X tool from Helmut Zepf. And if I feel movement on the buccal plate as well, it means that they are not separated properly. Whereas if I'm moving the palatal plate and I feel no movement, I can safely say that they are not joined, and I can take out the palatal plate easily. So here you can see once I've got everything out, I'm now thinning out the whole socket shield. So this is the preparation of the socket shield. I'm using the same drill, and now I'm going to remove the apical portion, make sure that I've got the apical portion. So I've angled my drill slightly towards the buccal to take out that apical portion, remove it in total, and especially if there was any infected material or granulomatous material down there, you want to remove as much of that root section as possible. But as I said before, there's no data to say that you can't leave the whole buccal plate, and in a number of cases I have done that. So here you can see we've now thinned it out to the thinness or thickness that we wanted. And now what we're going to do is we're going to use a long-shanked green ring Comet drill. And for anyone who wants to know, I've got the codes. If for anyone who wants to get the codes, you can get them a little bit later at question time. But here you can see just the preparation. Now I want you to notice that I'm using an instrument to retract the gingiva, and this is absolutely critical, because what it's doing is it's not allowing me to thin out the soft tissue or traumatize the soft tissue at all. Okay, it also means that I can trim down to around where 1 millimeter is, because if I don't do this, I nick the soft tissue, and every time I nick the soft tissue, I thin out that soft tissue. And you'll see one of the complications I had as a result of this, where we actually got exposure of the socket shield because of the fact that we didn't protect it. So it's very, very important to get some kind of instrument, and this is just a Miller's curette that I've modified to use. And here you can see how we slowly but surely remove and create that socket shield that goes 1 millimeter above the buccal bone plate and around 2 millimeters below the gingiva, the buccal gingiva. So here we go again, you can see a sharp edge. So it's very important to remove those sharp edges, and I'll show you again why when we start to deal with the complications after this video. But you can see how important the preparation, and again, slow preparation. Don't be hasty. This is not a race. This is a marathon. We want this to last the patient for the rest of their lives. Okay, so there again preparing Just using that, and eventually we're going to change. We're just thinning out the top part again, taking off all the sharp edges that we don't want any sharp edges there, removing those sharp edges. And once we've done this, what I am going to do is I'm going to change to a slightly smaller round drill, which is a blue, a slightly less rough diamond than this one. And once we go to the blue is a smaller diamond we use, which is about a 1 millimeter diamond, which allows us to just more polish the edges, take off the sharp. Here you can see a slightly smaller diamond, just to polish the edges off, take the sharpness off all the edges, but without doing any damage to the soft tissue. You can see as well some of the cementum left behind, which we remove with the periotome. Once we've got that out, and that happens often with diseased teeth, where they actually leave a little bit of cementum behind. And you can see in the mirror, again, using a stent. We do not use any case. We use every case we put a stent in. We do single tooth, multiple teeth, immediate, doesn't make a difference. We use a stent to make sure that we get our positioning correct. And again, using Cavani's suggestions, and I think Evans and Chen as well, we go palatal, we go deeper, and we angulate it deeper. We place our guide pin in, we place our stent to make sure that everything's in the right position, and we take x-rays, but we're not going to go through this process. This is just your standard immediate implant protocol, keeping some of the bone that we're going to mix with the xenograft at a later stage. And here we're using a Megagen 4 by 13 millimeter implant, which we place with a handpiece into position. Again, making sure that we get good palatal placement. And there it's already stopped at 50 newtons turn-in torque, using the hand wrench to seat it to the ideal position. And I place it around 2 millimeters below the socket shield, so that we make sure that we're about 1 to 2 millimeters below the buccal plate of bone. So you can see there a very small jump gap, and I don't like the jump gap, so I'm going to fill that jump gap. But before we do that, we're just going to check the ISQ and make sure that the ISQ levels, as described by Peter Moy, we want to make sure that the ISQ levels are around about 70 to 75 before we do immediate load. We can also check and see with the guide pin in place to see that the implant's in the right position, which it is. We now place a small cover screw so that we don't pack bone into the implant itself, and it's just easier and cleaner to work this way. And now what we're going to do, we're going to mix a little bit of APRF, Chukrin's APRF, with a little bit of xenograft. We're going to mix the two together, and we're going to pick them up with a sterile diabetic syringe, which we've just cut the edge off, which is nice to carry the bone into the area, and just pack that apically with a metal probe. Some people might say don't use a metal probe, but it does no damage at all. Use a metal probe. Don't use plastics, because I found plastic generally causes an infection because some of the plastic comes off as you're pushing it down. And the buccal plate has now been filled, and now we're going to place an indexed titanium provisional abutment. And what we're going to do now is just mark off where we want to cut it off, so that we can attach it. And I'm going to put a mark on the next door tooth, and that's just to tell me, because I take an x-ray now to check it's seated, and when I put it back, I'll just know that when I can check it, as I'll show you, to see that it's at the right level without having to take another x-ray. So here, using a wheel just to take off the top, screwing the whole thing back into position, and you can see just making sure that we get everything there, not seated properly, coming out, putting it down, getting it into the right position, and once it's in the right position, down it goes. And we can just put something straight level so we can see without using an x-ray. We then take our shell of our tooth, putting it back into the impression that we took, and just taking a long-shanked tungsten carbide burr and just cutting a hole where the screw is going to come out. We're going to do screw retained crowns. I do not like using cement retained crowns at all for provisionals because of the risk of getting cement into the socket. Checking to see that the hole is right, that we can get access to the screw. And what I use here is just a small toothpick. You can use a burr, a latch grip burr, if it fits in nicely. I use toothpicks, and I put a little bit of Vaseline around the toothpick. We check and see that everything seats nicely and passively without anything happening. And because we're going to use composite, flowable composite, I cut out the buckle of the index so that I can use so that we can actually have space to cure it. And with composite, we're just going to, this is a composite shell, so we're just going to use bond, but if you need to, you'll actually have to, if it's porcelain, you'd have to use porcelain bond, etc., and etch, etc., the 45% orthophosphoric acid, curing it, and putting Vaseline on. And once the Vaseline's on, you can see on the stick, you can see now what we're doing is we're flowing composite around the top only. We are not flowing composite into the socket, because if we do and some get stuck there that we don't notice, it can cause a massive toxic reaction. So only around the top, not subgingival. We're now filling up the crown completely filling the crown up, and we put that over the top, which will then index everything absolutely perfectly. And we push it down, and because it's got Vaseline on, it doesn't stick. And once it's in position, we cure everything together with the curing light. Once that's cured, we can then take the toothpick out. Once the toothpick's out, we now have another hole that we can now start to cure from the top. So again, we're just making sure that all our composite is cured well before we take the index out. Once we've removed the index, again, curing from the palatal side to make sure that everything's cured nicely. And obviously, once we've got everything cured and well indexed, now we can unscrew very, very well. You can see how nicely the toothpick has kept our hole open. There's nothing's got in there. The minute we take it out, we make sure we cure it again to make sure that all the stuff's got has bonded nicely and that our indexing doesn't move. And at this point, it's also very good to go into your socket and check and see that you haven't left any composite behind, because as I said, if you leave some in the socket, it will cause a toxic reaction. So here what we're doing is we're filling in all the voids with further composite, which is flowable composite, which is such an easy way to do it. You can add all the flowable composite in there. It's easy to add, easy to subtract. Getting the right colors, so you've got a wide range of colors. And we're just adding all the flowable composite, then we'll cure it. And once it's been cured, we'll take a rubber wheel, a white rubber wheel, and we'll start to shape the crown. We'll start to create the S shape that we want to allow thick tissue to form between everything. And here you can see the rubber wheel that we use to start shaping the soft tissue portion, the subgingival portion. Very important to create that S shape to allow soft tissue to remove the excess bulk on the palatal side and to make sure that there's going to be no occlusion on this crown. So here you can see very much getting everything into nice shape. And going over to the palatal side and creating that S shape. It's very important that you make sure that your temp or customized abutment does not touch the socket shield. And the reason for that is if you do allow it to touch the socket shield, there's no ways that soft tissue can grow down between it and you'll have an exposed socket shield. So you want it as far away as possible. You want some space between the socket shield and the provisional. And before we try it in and check and see what's going on, you can either polish it. You can either polish the margins with composite polishers, or as we do in this case, we add what's called temp glaze, which is a non-filled resin, which we just paint on, which gives you a high gloss finish. And what it allows you to do, then you don't have to sit to worry about polishing, but it gives you a very high gloss finish so that you get less plaque accumulation subgingivally, which is very important, which will happen if you have a rough surface and will irritate the soft tissue quite dramatically. And we cure that nicely there. This is a product, I think it's available from Ivoclar. And you can then just wipe that off, make sure that there's no excess resin. We then go the dual zone therapy technique and we add a little bit more bone into the top just to support. And that will just help to push the soft tissue out. And we then place a little bit of chlorhexidine gel onto the screw so that we have a nice sterile well. And in that gets screwed into position. And you'll see as it's screwed into position, it supports the soft tissue nicely. It supports everything nicely. And again, making sure that you've got the right torque, because you want to torque it down properly. And this system goes to 35 Newton centimeters. And you can see the occlusal where the screw's coming out very, very nicely. And what we're going to do now is we're just going to fill up that screw hole with little bits of what we call plumber's tape, or it's just PTFE that we use for plumbing. The reason we use this plumber's tape is that PTFE, as you know, polytetrafluoroethylene does not accumulate bacteria. So we don't use cotton wool pellets and things like that, because usually when you take them out, they're smelly and they've got bacteria all over them. And these things are nice because when you put them in, they're white. When they come out, they're white. Because there's no bacteria accumulation on them. And you can see you can pack it nice and tightly as well into these areas, and they're very easy to remove with a sharp probe. And then we're just going to add a little bit of flowable composite to just seal up that back. You can add something like something soft, a temporary liner on there, but I prefer to put something hard myself. And curing that area, get everything nice and solid. And again, making sure that with your occlusion that everything's kept out. There is a new occlusion testing device coming out hopefully soon in January. But here you can see absolutely no occlusion on the tooth, a very protected occlusion. It's all on the adjacent teeth. And we can now wait for that to heal and for everything to integrate. And once we get good integration of that, then we can place our final crowns. And if you have a look, you can see there's space between the abutment and the crown. There's good space between the implant and the socket shield, and we should get a phenomenal result with this case. Okay, so I think you've pretty much got a good idea of how to do the socket shield. We've gone through it, I think, in a very didactic way, both with pictures and with video. And as I say, some of the other videos on Dental XP also show you really good graphic stuff, which really gives you good explanation. You can certainly go to those and watch them, so you get the best idea about the technique. But let's look at a little bit of the complications that I've had to deal with over the last few years. Some of them mine and some of them other people's. And here you can see a lower socket shield technique, which I think is very, very difficult to do in the lower jaw, much more difficult than the upper jaw. And also, I don't think you can do socket shields of the anterior, of the central and lateral incisors, because they're just too thin. And as a result, there's just not enough space for the socket shield and the implant. But you can see on this canine what's happened. You can see the exposure of the socket shield on the buccal. And if you have a look at the cone beam, you can actually see why. The reason is that they've left a sharp edge on the outside of the socket shield, number one. And number two, the socket shield is too high. And as a result of that, there's a problem with it. So the way we dealt with this case is we actually raised a full thickness flap, okay, keeping the hole intact and raising a full thickness flap. We didn't raise and take out the socket shield. We cut the socket shield back. We made sure that there was no sharp edges. We protected the soft tissue. We packed more bone. We let everything heal. And you can see here, this is a case that's probably about 2 years old now. You can see the beautiful soft tissue healing, everything happy. Although the fact that we've lost a vertical height because of the fact that we lost about 1 millimeter to 2 millimeters of that soft tissue, but had we not had that complication, you can see the buccopalatal maintenance, and we probably would have had a much better aesthetic result from a gingival recession point of view. But again, we were very lucky, right choice of case to start working with, low aesthetic value, low lip line, and no real problem in the long run. And here you can see the long-term 2-year post-op scans of the case with the socket shields in place and great buccal bone, no collapse of the buccal bone at all. Everything's still happy and healthy, and a great situation. Let's have a look at the next one, which is really the infection of the socket shield. And here you can see the classic type of scenario that we did at a later stage. Now here you can see the removal of the palatal side, and you can see here was one of the cases where we actually thinned the part out too much, and it was about 1 millimeter thick, and as a result of that there was a lot more flexion in the root. And even though it was firm, so when I took my tweezer and I shook it, it was still firm. We put everything back and we put our provisional crown back, and everything was hunky-dory and looking fantastic, taking photos from left, from right. Everything was great. We were expecting a phenomenal result, and the patient came back 1 month later, and oh dear, what have we got now? Okay, so what happened is that the socket shield in the meantime had come loose, and when we did an aesthetic buccal flap to open up, we had lost all the bone, and we had to take out the socket shield. The implant still had a very good ISQ, so we decided to leave it, and we didn't want to take out and start again. And we basically ended up decontaminating the implant, and the technique I use for decontaminating is a diode laser on 1 watt for 10 seconds, and then using sodium bicarb with a Profijet, which I find cleans the implant absolutely phenomenally well. And then from there on out, we then went for a classic Wang sandwich technique, where we placed synthetic bone, we placed a Jason membrane, pins, PRF, etc., etc., and closed everything up. And you can see the socket shield that was loose, that was taken out, everything closed together. And you can see when everything came back and everything had healed, you can see we had good bone on the buccal, as can be seen from the scan. And you can see not a bad soft tissue result. And should we need to, we now have the option of going to do a further soft tissue graft to give us further bulk, to make sure that we even get a better result with this case. So everything was salvaged, and this is why I think if you look at this case, it explains why I emphasize the importance of position of the implant. We know from Evans and Chen, we know from Schropp, we know from Botticelli, we know from Cavani how important that position is. So I don't think we need to change our positioning of our implant. We need to place it palatal, we need to place it deeper, so that should we have these kind of complications, we have everything, all our ducks in a row, so that we can easily treat that complication. Here you can see another case where we loosened the socket shield intraoperatively, and really it was just a scenario where, again, I was using the implant drills, and as a result, as I was getting wider, I vibrated the buccal part loose, and as a result of that vibration, I had to take it out and just do a standard immediate implant case. Here's another case that I'll show you. This is a failure of integration, and the reason for the failure of integration again was because I used the implant drills, and because the implant drills weren't getting cooled enough, I actually overheated the bone. So everything looked fantastic. We got a phenomenal result. This is the case I showed you earlier with the beautiful soft tissue, and everything was great, but unfortunately the implant wasn't integrated. We had to take the implant out. The interesting thing, though, is when I raise the flap, look how phenomenal the bone is on this case. You can still see on the left-hand side where the arrows are, you can see the buccal bone, you can see the buccal plate. And as a result of that, we were able to still place our implant, smooth everything off, clean everything off. And you can see with our bone still intact, we're still going to get a phenomenal result. We've closed it up. We're waiting to check integration with this one in a few months' time. And still a phenomenal result. So if we can go to that in summary, the technique of socket shields is really an unbelievably phenomenal technique, and it's certainly something that's going to be part of our tooling for many, many years to come. The problem, sorry, I've just gone through that a little bit fast. The problem is that there's no long-term data, and we're still waiting for the 5-year data to come from Hertzler and Boehmer, which hopefully will come out in the next year or so. But essentially, the kind of aesthetic results that we're starting to achieve with this, with thin implants, with multiple implants, and I've got some new stuff of mixing this with root submergence and stuff like that, where we're really getting unbelievable stuff. But I warn you, it is not easy to master, and for those who are starting out with immediate implants, this is an advanced technique, and I would strongly urge you to go through the immediate protocol first and become au fait doing immediate implants before you start taking on the socket shield technique. And with that, I say thank you very much for listening. Please send questions. My email is below if you want any further information or you want to ask any further questions offline. You can go to the blog online, and there's certainly a hell of a lot of cases online at Dental XP that you can go and look at, and there's a lot of questions answered, a lot of great discussion from really great practitioners. And I say thank you for listening. Thanks for Dental XP. I really appreciate the time you've given me to present, and I look forward to some future work with you.